Introduction to Nursing Concepts, Nutrition Unit. This is Martha Olson. As we look at nutrition, we know that about 40 to 55% of our adults that are hospitalized are either malnourished or at risk for being malnourished. So we need to, on admission, do a screening to be able to identify them early and then put things into place that would help prevent that. Chapter 44 in Potter and Perry is the chapter. This site is now outdated. It is updated to the myplate.gov. If you've taken a nutrition class where they utilize this, you probably are very familiar with the fact that this is put on by the government. It helps calculate daily food intake, calories, fats, carbs, sodium. So it can be used in preventative, but also in looking at, is somebody that's getting this amount of food getting enough? So we can tailor it for pregnant women, for children, and it's very interactive. It even has a site for children to go to that's at their reading level. The principles of nutrition you have covered in your nutrition class that you've taken previously. When we start looking at the principles of nutrition for nursing, then we start looking at balanced nutrition being things like a stable, healthy weight, adequate hydration, they have good skin turgor, mucous membranes are moist, urine output is adequate, lab values are within normal, they have energy, they are able to fight off or decrease the amount of illness they have. This is discussed in your Potter and Perry on page 1011. When we look at nutrition imbalance, then it's that involuntary loss of more than 10% of their weight, 20% or over or under of their ideal body weight. I'm not a real big one on looking at BMI because somebody that's very muscular is going to have a very high BMI, which almost makes them look like they're obese when they're not. So I kind of take the BMI with a grain of salt and kind of look at the overall person, their physical fitness, their endurance, their ability to, get around and do things. Situations where we would want to encourage fluids would be a patient that has a healing wound, somebody that comes in dehydrated, anybody with a fever, because remember they're going to be breathing faster and they're also going to be sweating with that fever, anybody with an increased respiratory rate, and then your diaphoretic patient. As we look at risk identification, we look at those patients that, after a stroke that are having problems chewing, those patients that are having difficulty with swallowing and not aspirating. Have they been nauseated? Maybe this is a cancer patient that's going through chemo and radiation and they really have no appetite, they have mouth sores, they're becoming very anorexic and losing weight, looking very cachexic. Socioeconomic, can they afford meat? Can they get to the grocery store? Do they have the income to be able to buy groceries? Our alcoholics are a whole other area of risk identification because they get adequate calories. They're just empty calories, so their tissues, their health inside is probably very lacking. They have cirrhosis of the liver most likely, but yet their weight, as you look at them, may be near normal. When we do a swallow evaluation, then that's usually done by a professional swallowing evaluation expert, and they look at the different types of swallowing and make recommendations for the type of food that they want the person to have. When we look at the types of dysphagia for this test, I'm not going to be real specific or be looking for you to know that, because as a nurse, our big thing is to look at, are they having the signs of dysphagia and choking where we need to hold off feeding them and get an expert to come in and look at them, and then can we appropriately feed them and manage that when they have dysphagia. Our interventions then are having them sit upright, giving them small bites of thickened fluids, because thickened fluids go down slower. It allows those muscles time to close off to the trachea and open to the esophagus, and they do not recommend using straws. When we look for aspiration precautions, you will want to refer to Potter and Perry on page 1026 at skill 44. On point number 6, it talks about the thickener that's used. I always mix it at the bedside because it gets thick really quick, and if you do it in the nutrition room, sometimes by the time you get it down to the patient, it's not appropriate. On number 7, it talks about 1/2 to 1 teaspoon of food on the unaffected side, and then swallowing twice is often necessary for them to clear their pharynx. So you have to be very patient when you're at the feeding table or feeding somebody because of that. Our warning signs for dysphagia are listed here. That's silent aspiration without the cough, and that's where listening to the lung sounds is going to be important, because you will start picking up kind of that moist aspiration kind of sound when you auscultate the lung sounds. This is on page 10. The other thing we want to look at is that slow, weak, uncoordinated speech is usually a warning sign that you're going to have some problems. And like I said, most of these patients are ones that have had a stroke, and we're just really trying to figure out what the damage is for them with the stroke. When we look at our assessment, our subjective versus objective, we want to work closely with the dietitian. We want to ask the client about their eating habits and food preferences, determine if they have any special dietary practices related to their culture, observe their dentures, look at the gums for any sores or pressure areas, look at a 3-day diet from the client. Some of the other things we want to look at is their muscle mass. We do not have to have an order to get a daily weight or a weekly weight, so go ahead and initiate that. Look at their exercise. What is their ideal weight? And then weigh the patient and look at the lab values to kind of help determine what's going on. Some of our lab values we look at: your CBC, pre-albumin. Remember, that is the one that has a shorter half-life. It's going to tell you more about the last week. When we look at the albumin itself, the half-life is about 21 days, so it's not as accurate for short-term protein status. It's maybe a better indicator of more of your chronic illnesses. Transferrin, that's about an 8-day half-life. After test result, or things that alter test results, would be things like their fluid balance. If they come in very dehydrated, of course their CBC is going to look like it's elevated or even normal. When we get the IV in and get them hydrated, those hemoglobin and hematocrit levels may drop. Their liver function is going to obviously alter your lab values, and so you're alcoholic or somebody in liver failure. Kidney disease and then other disease states may affect your lab values, so you have to look at those with that consideration. Indicators: your anemic patient is probably going to have a low red blood cell and hemoglobin. BUN is your kidney values, but that can be changing with hydration. So your better indicator of kidney values is your creatinine level. And then when we look at your urinary nitrogen, we know that nitrogen, positive nitrogen balance then is looking at some of those proteins. From the diuretics that you've had in your pharmacology, we know that many of your loop diuretics are potassium depleting, like Lasix and Bumix, and can alter some of your lab values. When we look at our nursing diagnosis, my number 1 is listed there, your aspiration, because that's airway. That's looking at compromised airway for that patient. When we look at fluid volume deficit, we think of, the dry skin turgor, very dry lips, very dark concentrated urine. So behind these bullets, you want to study what will the patient look like? What will my nursing assessment want to look at? Our fluid volume excess is somebody that's come in and either had too many IV fluids, drank too much, or their kidneys have shut down and they are not able to remove any of the fluids from their body. Those would be people that have gained weight. You weigh them yesterday and you weigh them again today and they're up 2 or 3 pounds. They're short of breath, they have crackles in the lungs, they have that pitting edema to the extremities. And then with fluid volume excess, they're probably voiding a lot with polyuria with light-colored urine. Causes of fluid volume deficit, we would again relate that to maybe a patient that's had nausea and vomiting, diarrhea, fluid volume excess, IV fluids, either accidental or maybe the patient has congestive heart failure and they can't tolerate that very well. Other nursing diagnosis that you could list: imbalanced nutrition with weight loss, and imbalanced nutrition more than body requirements would be weight gain. The NICs that go along with this unit are listed here. We have the nursing intervention classification nausea management, and that would be your antiemetics, offering, bland foods that they tolerate well. Our diet staging is looking at what type of diet is most appropriate for them, and perhaps you have an order for advanced diet as tolerated, and it's kind of up to nursing judgment to decide which one is most appropriate. Are they ready to advance to a clear liquid after NPO, and then back up to maybe a soft diet and then a general diet? As we plan therapeutic diets, these are all listed. You would want to be very clear on what can they have in that diet. When we look, at clear liquids, you should be able to see through them, versus a full liquid would be, your milks or more of your creamy things that you're not able to see through. These are found on page 10, 17, box 4410. And then also advancing a diet on page 10, 17. Many times, like I said, your advanced diet as tolerated order comes from a surgeon post-surgically, waiting for a patient to tolerate it, waiting for bowel sounds, and the best thing you can do is to get them up and ambulate them so those bowel sounds start coming back. Again, when we look at clear liquid, it's clear fruit juices, so it would not include orange juice. And then your full liquid is some of your dairy products and things like that, like cream soups. NPO, the reason we do that is usually because they're a risk for aspiration. If they have an ileus and things are not going through, if they have vomiting and diarrhea, it's pointless to put something down that they're going to vomit and aspirate up. We don't want to keep anybody NPO longer than 4 to 7 days with only just IV fluids, because that would put them at high nutritional risk. So if you have somebody you're anticipating a little bit longer NPO status, be working with the doctor and the dietitian to get your plan ready so that this person doesn't get real malnourished before you decide, hey, we need TPN, or we need, a PEG tube or something to get them going. For the patient that's NPO, frequent oral care is always appreciated. Just because they can't eat doesn't mean we can't, moisten their lips, do good oral care, rinse, use mouthwash. With our dysphagia, the different types of diets are listed here. Your 4 levels of liquids are listed here. Your thin liquid, usually if somebody has dysphagia, we usually get them up to a honey-like or honey viscosity so that you spoon it off. Typically, patients will tell me they appreciate cold water that's thickened because it kind of quenches their thirst. When they have problems swallowing, these are some of the foods that are appropriate for those types of diets. Your advanced dysphagia diet then is moistened breads, maybe some peeled soft fruits, so the skin is removed from an apple, from a pear, baked potato, but again, no skin to that type of diet. Other diets, if we would need fiber because they're having some problems with constipation or diverticulitis, our bland diet usually avoids coffee and raw vegetables, anything that's GI irritating. And sometimes the rule of thumb has been, what the patient's hungry for, what they will tolerate. And I've had patients before that the doctor will say, if they want a piece of toast, let them have it because they're able to tolerate it if they're asking for it. Your other diets that you should have had in nutrition class, we see a lot of low sodium. We should all be on kind of a low sodium because that goes along with hypertension. So a lot of your cardiac patients, patients with edema will be on a low sodium. Your diabetic diet is looking more at counting carbohydrates so that they get the appropriate amount of carbohydrates with each meal and snacks so that it controls or helps regulate that blood sugar. As we implement then, we want to assist with feeding. That's found on page 1018. Again, you want the patient sitting upright. You want to observe them for choking and have suction available in case they would get into trouble with that. And then for monitoring intake and output, we want to record how much of the meal is eaten, not just 1/2 or 3/4, but 4 bites of the mashed potato, half of the applesauce. So it's a lot more specific. So the dietitian, in calculating that, can determine they really are or are not getting enough calories for the day that we need to do something. And then we will talk about parenteral nutrition in the next segment. So as we look at this first part, We have a lot to think about as far as diets and nursing orders or things that we can do. We'll go on to part 2.